I'm Susan Swain, host of C-SPAN's Q&A, where we spend an hour with nonfiction writers and historians who add context to today's news. Columbia University cancer researcher and Pulitzer Prize-winning author Dr. Siddhartha Mukherjee is deeply involved in COVID-19 response strategies. For this episode of Q&A, we spent an hour with him talking about many aspects of the coronavirus pandemic.
Of all of the decades that I've been involved in chasing infectious diseases, I've never seen anything that is so protean in its ability to make people sick or not. There's no other infectious disease that goes from 40% of the people having no symptoms to some having mild symptoms, to some having severe, some requiring staying at home for weeks, some going to the hospital, some getting intensive care, some getting intubated, some getting ventilated, and some dying. So that depending on where you are in that spectrum, you have a different attitude to this particular thing. But anyone who gets infected or is at risk of getting infected, to a greater or less degree, is part of the dynamic process of the outbreak.
That is Dr. Anthony Fauci describing the various outcomes so far of COVID-19. Dr. Siddhartha Mukherjee, you won the Pulitzer Prize for a book on cancer that proclaimed it the emperor of all maladies. How is COVID-19 shaping up as a biological foe?
Well, as Dr. Fauci described it, it is a protean foe. We are just in the long span of human history, we have just basically encountered this novel coronavirus. And we're still learning things about it, which are really fascinating, somewhat counterintuitive, things that we hadn't thought about before. I should tell you that I'm an oncologist, but really my training, my PhD, is in viral immunology. So the features of virology are very familiar to me. And I would echo Dr. Fauci's opinion on this. In my lifetime, I've seen, influenza pandemics move by. I saw from a distance SARS. I worked on influenza for a long time as a graduate student. I have never seen anything like this. The strange features of this virus are truly something that are out of the ordinary.
How does its strange features complicate our ability to conquer it?
Well, let's talk about some of these strange features. The first strange feature is the vast degree of asymptomatic and pre-symptomatic carriers. So, you might be walking in the community, and there might be someone who, in a closed space or in a closed environment, who's not really symptomatic, but is carrying the virus. They may get symptomatic days after, so there's a pre-symptomatic period. Some of them don't even they have extraordinarily mild symptoms. And so that makes it extremely challenging because you can't simply isolate and contact trace these people based on symptoms, since they don't seem to have symptoms or they may be pre-symptomatic. And that means that the only thing that will work if you're in close proximity with them in a closed, crowded space, the only thing that will really work is masking and social distancing. So that's one feature. The second feature is we don't know what the relationship is between why some people seem to get infected and some people don't seem to get infected. There have been now a series of extraordinary reports. I mean, the one that struck me the most was that it was a report it's still in preprint, that I read from a cruise that went to the Antarctic. So on that cruise, one person was infected to start with. They were isolated to the best of their ability, but unfortunately, the virus is extremely contagious and it spread. And if I'm remembering the numbers correctly, 60% of the people on the cruise got infected. But here's what's very interesting about it. There were couples sharing the same room in which one of the couple was infected while the other one was not infected. So in a closed, crowded space, for reasons that we still don't understand, we have now evidence or accumulating evidence that some of this may have to do with previously existing cross-reactive immunity against other coronaviruses, possibly. That may be one explanation, but that's probably not the only explanation. There are probably other explanations as to why some people seem to be exposed but not infected. So that's conundrum 2. Conundrum 3 is how much virus is required to have an infection. So I wrote a piece in the New Yorker, which I would encourage people to read, called How Coronavirus Behaves Within the Patient. We don't know whether there's a relation for many viruses, including influenza, and for many respiratory viruses, there's a relationship between the dose of virus that you receive and, of course, the chance that you'll get infected, and also potentially the severity of the disease that you have, because it's a dynamic battle between your immune system and the amount of viral load exposure that you're getting, which is, again, to emphasize why it's important to reduce that viral load. And to reduce the viral load, as I said, masking, social distancing, and the 3 C's, close spaces, avoid close contact, avoid crowds. The 3 C's are extraordinarily important. So that's yet another conundrum. Now let's get to the fact when the virus is actually in your body, it of course affects the lungs. We knew that. It's a respiratory virus. It seems that the virus the infection really has 2 phases. Phase 1 of the infection is when the infection is being driven primarily by the viral infection itself. This is when your lung epithelium cells are being destroyed, and you may have a fever, you may have chills, and the famous loss of smell, loss of taste, loss of appetite, etc. But then that moves in some patients, but not in all, and we don't know why. In some patients, particularly men, it moves towards the second phase of the infection, where the pathology is being driven by the exuberant, or at least an immune response to the virus and to dead cells that are accumulating. And that phase is very dangerous because your air sacs, which is where air exchange occurs, fill up with immunological debris, debris from dead cells, and fluid inflammatory consequences of the virus. So why this virus behaves in these 2 phases, whereas some other viruses don't, again, a mystery. If I may carry on, there's 2 or 3 other mysteries I'd like to highlight.
Sure.
Then comes the question about what else does the virus infect? So it turns out that the receptor that the virus uses on human cells has now been established. We don't know if there are co-receptors. Certain viruses do have co-receptors, but at least a major receptor has been identified. The virus, for reasons that we don't understand, causes a diffuse set of symptoms. So I will name some of these symptoms. In children, it causes in a small number of children, it causes an autoimmune disease of the blood vessels and the arteries, very similar to a disease called Kawasaki's arteritis. Why this virus is causing a Kawasaki's-like syndrome, we don't know, but now, as of yesterday, there was a big case report of all these children. It also causes, what has become very clear, a state in which your blood tends to clot more. This blood clotting can lead to strokes. It can lead to cardiac attacks. It can lead to basically blood clots being sprayed in various parts of the body, including the lungs, where it can be life-threatening. And then just to make one last point, we still don't know what the long-term sequelae of infections are in people who survive. So let's say you do recover, hopefully, from the coronavirus infection, and let's say you have a severe infection. We don't know what the long-term sequelae are. I mean, people are finding kidney problems, arthritis problems. Some of these may or may not be related. Some of them may be related to the fact that they were in the ICU. So I've just given you, right from exposure right up to the end of the disease, a series of truly interesting, and I would say devastating things that we just don't understand. We're beginning to understand some of it. As I said, I gave you some clues about what we're understanding, what we're not understanding. And in each, as we understand each of these phases, it's important to recall that different interventions will work in different phases. So obviously, once you are in the ICU, it's the healthcare workers that need to be protected from you in terms of viral exposure. But depending on what phase of the infection you're in, whether you're in the so-called virological phase in which you have exuberant burst of viruses, or whether you're in this inflammatory immunological phase, in fact, the medicines that work for one don't seem to work for the other. So antivirals such as remdesivir and now new antibody cocktails from several companies work or are likely to work, and we know they work based on good trial data in that first phase of the infection when you want to kill the virus, but seem to have no effect whatsoever in the second phase when you have that inflammatory response. And there it's anti-inflammatories such as steroids and a bunch of other medicines that seem to work, whereas the antivirals don't seem to be doing very much in that phase. I would say that we are involved in 2 or 3 projects to address both phases of this infection.
So as complicated as this is, it sounds like really only time, lots of experimentation, and a lot of information sharing is really the key to understanding and really attacking this disease.
Yes, and ultimately, I should say that I have not seen a level of collaborative spirit within the scientific community of this ilk or stature in my life. That's very encouraging news. Things have moved as fast as they can possibly move. We will have, hopefully by the end of this month, 2 to 3 to maybe 4 potential drugs, including antibodies, that will attack the virus. These are still in advanced phase studies, so I can't comment on whether they work or not, or which or what settings they work on. And we will also have about 4 or 5 or 6 new modalities to treat the inflammatory phase of the virus, including, as I said, steroids, but also protein-based drugs. And in my case, we are experimenting with a special kind of T cell which can dampen this immune response called a regulatory T cell. So this is moving as fast as we can. Of course, we will have to wait for the vaccine. And optimistically, I think most people think that will take about 18 months.
So focusing on the United States, we're talking at the very end of June here, and at this moment there are 2.64 million known cases in the United States, 128,000 deaths, and as we've all seen on the news, cases are on the rise in as many as 29 states. So overall, how would you assess the state of the United States response to this virus?
Well, I think again, I would encourage people to read a very long piece dissecting some of this that I wrote for The New Yorker called What Coronavirus Has Exposed About American Medicine, where I go through piece by piece by piece every step of the response. I think it is, despite best efforts, I must say that the initial response in the United States was abjectly problematic. I cannot describe to you what might have happened if we had taken faster and more decisive action against the virus when we knew that that there was a pandemic brewing in China, and when we knew that cases were already spreading into parts of Europe, including Spain and Italy. Crucial mistakes were made during that time. I'll just give you 2 examples. One example was the lack of testing in the early phases. Now it's extremely late, but in the early phases, testing and isolation, the strategy that worked in Wuhan and now more recently in Beijing, should have worked and would have worked if the number of cases had been low. There was a 42-day delay. I'm going to repeat that. There was a 42-day delay from the day that the first coronavirus patient appeared in a hospital in near Seattle in Washington state, to the day that commercial testing for the virus became available. 42 days in the lifespan of a highly contagious virus may as well be a century, because by that time people have taken flights, people have moved all around the United States, and the sparks of the original virus were spread all over. That's one example. The second example is that the CDC and other authorities made what I think was a crucial error in not asking people to isolate, mask, and maintain social distancing as soon as, even while those tests were being made. And secondly, in particular tragedy is that we were desperately unprepared, not just for testing, isolation, and quarantine, but also to give healthcare workers in particular and frontline workers the really protective masks, the PPE masks, or the N95, not the PPE, but the N95 masks, which truly do protect against the small aerosol particles. And healthcare workers were in particular need of them. We've seen many healthcare workers die in this pandemic, and I feel extraordinarily sorry for them. But at the same time, encouraging the public to avoid the 3 C's again, crowds, close contacts, close spaces, and wearing masks and potentially eye protective equipment early in the course of the pandemic, and mandating that would have been a successful solution. We have now, I would say, strong to sufficient data to suggest that strategy works. Of course, it does not work 100%. No one expects it to work 100%. But in virology and in epidemiology, the reduction of spread of a virus from one person infecting 5 people to one person infecting less than one person, in other words, driving the infectious spread, is of great consequence. So you don't need a strategy to work 100%. All you need to do is to decrease that famous number called the R0 or the R0, which is crucial. I'm going to make one last point here, and that's very important. The 2 pieces of good news is that the number of deaths in the United States has actually tapered off and is plateauing, and in fact is showing signs of decrease. I don't know why. It's, again, a mystery. Is it because we are seeing, this is the absolute number. So I don't know why. Maybe we are taking better care of patients, earlier care of patients. There's more awareness. Maybe there's less viral load spreading, again, because of masking, etc. So the number of deaths has decreased. But as you know very well, in places like Houston and Dallas, in Florida, in Arizona, the number of cases is increasing. And this is, most data would suggest that some of that is because we're doing more testing. Of course, if you test more, you'll find more. But a majority of data suggests that it's also because the infection is, in fact, increasing in its spread. So I would not rest on laurels, although there is good news. I would not rest on laurels. I would continue to watch, because the wave of deaths usually is about 2 to 3 weeks after the wave of infections.
So you've mentioned masks several times. I want to show you a clip from very recently in a congressional hearing of a debate between the chairman and a member about the wearing of masks. Let's watch.
We have to be consistent. And if you say, Green, I want you to wear a mask, sir, I'll wear a mask. You're the chairman of my committee. But I want us to make decisions based on sound data and information. Thank you, sir.
Will you yield for a question?
Yes, sir, I will.
Are you arguing that we should not meet in person?
No, sir, not at all. I
that
think
sounds
with
like the arguments you're making to me.
No, I don't.
Because there's no certainty, the mask may not work, but we know how the disease is transmitted. So if the mask has such a low probability of working, maybe we ought not be meeting in person.
If you're asking my clinical opinion, sir,
yes,
my opinion is that patients who are in high risk categories,
patients,
people, individuals, sure, anyone who's 65 years or older, Who
That's
has
me.
comorbidities should wear a mask. If you don't, I'm telling people in Tennessee it's not required.
So the unmasked member of Congress is also a doctor. The chairman is wearing a mask. But my question for you is, this debate over wearing masks is happening in the halls of Congress. Are we surprised that people nationally are at odds about wearing a mask or not?
Well, I mean, I'm disappointed in the sense that I don't understand I really have a hard time understanding why this is such a major issue. The questions asked by both sides in that debate, I don't know the people, were absurd questions. The first question is, are you suggesting that we stop meeting? No one's suggesting that you stop meeting. People are suggesting that when you meet and if you can, then wear a mask while that meeting is in progress. You can communicate through a mask with perfect fidelity. It's not the most comfortable thing, but being infected by a deadly virus and ending up in the ICU is not the most comfortable thing either. So the line of questioning is absurd. The second thing that's absurd about the line of questioning is that we cannot run a randomized trial of masks versus not masks, although some have been run. But right now we cannot run easily a randomized trial of asking, sequestering half the population, asking them to wear masks and asking the other not to wear masks for lots of reasons, some ethical and some logistic. The overwhelming evidence in the scientific literature suggests that masks work. They do not work 100%, but as I said, in order to reduce the rate of infection from this virus, you don't need anything to work 100%. You need to decrease the so-called R0 of the virus, which is the amount of virus that is spread from one person to another and the amount of contagion that's spread. And so the second absurdity, if you make absurd straw men, then it's very easy to throw them down. If you say, masks don't work 100%, so I'm not going to wear one, that's making an absurd straw man of a mask. It is again, the idea is to decrease the load of infection by a person who's symptomatic or pre-symptomatic, and it is amplified by the fact that the wearer, who may not be infected, is also protected. So if you ask absurd questions and say masks don't work 100%, should we stop meeting? This is not the mechanism of respiratory spread, all of which are factually incorrect, then you'll get absurd answers. We should have a consistent, simple, mandated policy. And I have encouraged over and over again the president to lead on this. We should have a simple policy that applies across, and governors should apply that policy because we have still a long way to go before this epidemic abates. And the last thing that we want to do is to have inconsistencies between people about this. And again, to me especially, the troubles that you have to go through to mask yourself in a closed, crowded space where you're having contact is pretty minimal compared to a potential gain. And sometimes we have to make decisions based on evidence that is, where the encumbrance to the patient or to the user is minimal, and the potential gain is there and maybe quite large. We err on the side of caution, and this is one example of erring on the side of caution. We wear seatbelts. We require licensure. There are many things where we could say, "Gosh, a seatbelt is an affront to my liberty. I'm not going to wear a seatbelt." But we have mandated the wearing of seatbelts. And so, similarly, I don't think it's a far stretch to mandate the wearing of masks. And of course, if you have a medical condition that doesn't allow you to wear a mask for whatever reason, then you may be an exception to that.
So the states where the incidence rates are rising are generally the states that have opened up their societies. I know you're serving on Governor Cuomo's commission on reopening the economy in New York State. Can you talk to us about New York City and what, as it opens up, and how you prevent it from becoming like Houston, or worse, like Beijing has experienced?
Well, again, I think what's going to happen in the best case scenario that I think will happen in New York City is that we will open in phases and watch every phase. The good news right now is that I think, to the extent possible, phase one is going well. I was just outside. Virtually every person who's entering a store is wearing a mask. There is legal immunity for a store worker to deny a person not wearing a mask entry to that store if that store owner should so decide. There is, I would say that after a very long period of time, we're seeing a dramatic decrease in deaths for instance, in our ICUs. Work is slowly resuming. I think the way to move forward is to next ask the question, at what phase are we safe opening? The particular concerns are schools, restaurants, and bars. I would say that we have a 3-month window, a very crucial 3-month window, when public schools will be naturally closed and private schools will be naturally closed. It is during this window of time when I think we have to act very decisively and to bring that R naught down to as low as possible. What will happen at the end of that period is very much, I think, what has happened in places like Beijing and to some extent South Korea. There will be local outbreaks. There will be local outbreaks because you can never predict, where things are coming from. Those local outbreaks will have to be contained using a combination of isolation, contact tracing, and potentially the use of medicines, prophylactic medicines, to prevent the virus from growing exponentially and prevent people from expelling that virus into other people's respiratory systems. I would add that New York has a particular special challenge, which many cities don't, which is that we have a very busy subway system. And we have to keep the subway system as the lifeblood of the city. We have to keep that subway system open. We have to keep it functioning. And the only way to keep that subway system open and functioning, again, is masking, hand hygiene, and limiting the number of people that can, limiting the crowds of people that are coming in. So it's a long road ahead. Phase one is moving as well as it could. There has not been a gigantic spike in New York City so far, and certainly not a spike in deaths. Phase two is going to be a big challenge, but we're moving towards it.
I wanted to spend a little bit of time on genes and COVID-19. Folks will see your book over your shoulder, and you recently finished a project with Ken Burns on PBS about the gene. How was the quick decoding of COVID-19's genome? How did it advance our understanding of the disease?
Well, it was absolutely crucial because without the genome, the COVID-19 swab test is based on the COVID-19 genome. It uses COVID-19's genome to figure out how to test, because essentially it is detecting the RNA from the virus in the secretions, either from the nose or from the oropharynx. It's secreting secretions from the virus. So without that genome, we could not have devised a test. It was impossible. That technology itself relies on genetic technologies that have appeared, over the last decade or 2 decades, I would say. And it was one of the fastest genomes to be sequenced, and therefore led to the tests. Secondly, the production of virtually all the antibodies against COVID-19 relies on genetic engineering technologies. So if you want to make an antibody against the spike protein of COVID-19, which is the protein that the virus uses to attach itself to cells, so that you can block that attachment and potentially create an antiviral drug. The production of that antibody requires recombinant DNA technology and other technologies that depend on the last, I would say, 50 years of genetic research. And finally, to determine why some patients are more susceptible than others, what the receptor that the virus attaches to in the cell, why we are having complications such as the ones that I told you, the blood clotting complications, etc. All of these require population genetics and widespread genetic technologies. So I cannot think of one arena of virology for COVID, starting from the antibody tests, contact tracing, all the way to the production of new medicines for, as I said, both the phases, the virological phase and the inflammatory phase of the virus. I cannot think of any one of those which has not been affected or not been progressed by the 50-odd years during which time we've been looking and examining and understanding how genes work and how to sequence them and how to understand them.
I'm sure people have read that viruses can mutate. So how do researchers keep up with those mutations?
But again, we use genetic technologies. We sequence the virus and we try to identify what the mutations are. You can use the sequence of the virus to figure out where the strain is coming from. Is it a European strain? Is it the Asian strain? Is it the American strain? Is it the Spanish strain? So again, once again, you use the technologies that have really emerged from the last 50 years of genetic sequencing.
You talked about therapeutic medicines. Is the understanding of the gene also useful in developing a vaccine?
Absolutely. It is, in fact, crucial to the development of the vaccine. I would encourage people, again, to read. I don't want to push things that I write, but those are the ones that I'm most familiar with. There are many, many pieces on the COVID vaccine that should be read. But vaccines come in various types. One type is just to inactivate the virus, so to make the virus and inactivate it and inject the whole inactivated virus. Those vaccines are hard to make. They're hard to scale, I should say. They're easy to make, but they're hard to scale to hundreds of millions, up to billions of doses, because you're working, in order to produce them, you first have to produce a live virus. And even if you weaken the virus, which was done in the case of polio, you run the risk of some patients getting infected by the virus because the inactivation hasn't been completed, or there's a batch problem. So that depends less on genetic or genetic engineering technologies. But all the new generations of vaccines that we're producing are basically dependent on genetic technologies, and I'll tell you some of them. There is one platform for making vaccines that depends on taking some COVID proteins and stitching them genetically into the backbone of a harmless virus that causes a common cold, but doesn't replicate in your cells. It's, again, using genetics. That virus has been mostly inactivated, aside from being just a delivery vehicle to carry COVID proteins into the cell and make the body react and make antibodies against it. So that's a platform, and in fact, the virus is made by, the virus is in trial by Oxford University, by J&J, and by several other companies use this technology to deliver the viral protein into the cells. There's a third platform for viruses. I'm not going to go through all of them for vaccines, which in fact dispenses of the virus completely and uses just the RNA from the virus, that is the genome of the virus or a part of the genome of the virus, coats it with something to deliver it into cells. And then that is the basis of the Moderna vaccine, which is also in advanced phase trials. So as you can see, all three of these technologies, aside from the live inactivated or attenuated viral strategy, the modern vaccines are cleaner, easier to produce, safer, and they all depend on genetic engineering technologies that have emerged from the last 50 years. I should say I was a student and still a close friend of Paul Berg's, who won the Nobel Prize for figuring out how to stitch two pieces of DNA, a harmless virus and a piece of the COVID virus that will not cause the infection but will elicit an immune response. And I'm proud to know Paul, because these technologies that were invented in the 1970s and 1980s have now become commonplace. They're usable, widely usable, and they can be used to make these vaccines. So it is a proud moment for science if we make a vaccine in this new way, this new genetic vaccine.
You recently moderated a panel that brought people from a number of different disciplines together for the New York Times. What did you learn through that conversation?
Well, I think so. Let me just remind you of who was on the panel. I moderated and led the panel. Peggy Hamburg, or Margaret Hamburg, Dr. Hamburg, was the former FDA commissioner. Dan Baruch, Dr. Dan Baruch, I should say doctor for everyone, because everyone is a PhD and an MD or an MD PhD. Dan Baruch is a vaccinologist, a virologist at Harvard, and is one of the leaders of the production of one of these genetically modified vaccines. George Yankopoulos is the head of a company called Regeneron, which has taken the lead in making therapeutic antibodies against COVID-19, and just published a major paper in Science showing that at least in animal models that it works. Dr. Susan Weiss is a coronavirus expert. She's worked on all coronaviruses and has been for years involved in coronavirus research. Did I miss someone? Dr. Hamburg, Dr. Weiss, Dr. Yankopoulos, Dan Baruch, and me. It was 5 people. Well, the important thing I think that we learned from that, there were many, many important pieces of information. So I would really encourage people to read it. Everyone had an important perspective in all of this. I think there are 2 messages that stand out, or I should say there are 3 messages that stand out. One is that vaccines don't magically appear out of nowhere. They take time to develop, and the safety bar for vaccines is extraordinarily high because we're giving the vaccine to people who are otherwise well. So the safety bar is enormous. There is a big anti-vaxxer universe, and there's a lot of suspicion about vaccines, which is all the more reason to make sure that once the vaccine does appear and is proven to be safe and is safe, that we actually vaccinate people against this deadly disease. The second thing that we learned is that because there is some time, most people say, 16 months, 18 months, 12 months, if everything goes well, everything goes on schedule, we have to do something in the meanwhile. Well, what do we do in the meanwhile? It brings us right back to where we started. We mask, we isolate, we protect, we open, we try to persuade our governors not to be cavalier, as I think many governors have been, and thereby responsible for an increase in hospitalizations and potential deaths. Being cavalier about a lethal, deadly, infectious disease is, these people, these governors should really answer for themselves. What is the evidence that allowed them to be as cavalier as they were in opening up, for instance, bars, restaurants, and other closed, crowded spaces where infection was inevitable? So I'm extraordinarily disappointed in the cavalier quality that many of these politicians took. to do this as opposed to opening in a phase-wise manner. But what do we do during this time? As you talked about, we go through protection measures, but also we invent medicines. We don't have a vaccine, but we potentially can invent medicines. We can put those medicines in trials. Those medicines include antivirals such as remdesivir. It's not a great drug, at least up to now, but it does work. And is now being moved into further trials, combining it and making it into a cocktail so that potentially the drugs will work. The antibodies we just said are not vaccines. These are antibodies, man-made antibodies that give you, 1 month immunity potentially and maybe able to treat the early phase of the viral infection. Those are being made and are in advanced trials. Today, I just saw that Regeneron went into a phase 3 trial. Eli Lilly and a company called Vir are also in a phase 1, phase 2, moving into a phase 3 trial. What other medicines work? Well, there are medicines such as drugs that will block the immunological response. In fact, I'm involved in 2 or 3 such efforts. One is to elicit a company that actually co-founded. We found a mechanism to elicit a brisk T-cell response against COVID-19, and that is in early trials at Duke University. That's a company called Myeloid. Another one that I collaborate with uses regulatory T-cells. These are T-cells to dampen the immune response. This is a company called Celenkos. And finally, there are new drugs such as tocilizumab and a drug from Cuba called itolizumab. And I should say that for full disclosure, I'm collaborating with and an advisor to itolizumab, again in trial for the inflammatory phase of the virus. So that's the second thing that one learned, that this is not a time to sit back and relax. This is a time to actively put into trial medicines that we have invented or others have invented that work or potentially can work on COVID. The final and the third thing that we learned is that having a vaccine is useless. Being vaccinated is useful. And that means, and this was a point brought up by Dr. Hamburg, that means that there is a fourth phase after you finish developing a vaccine. Getting that vaccine out to people safely and at widespread distribution is itself a mammoth logistic task. Questions like, does the vaccine have to be frozen? Can it be shipped in a dry form? What is the formulation? How many doses are required? Will it protect the elderly? If you do all your trials in young people and then find out that the most susceptible people don't raise a good immune response against it, then the vaccine is not going to be that useful. So there is an entire backstory, as it were, of not just developing any vaccine, but developing and deploying that vaccine and actually vaccinating people in large numbers to be able to get to the point that you want to get to.
Well, on that last point, let me bring 2 voices in on the manufacture and distribution, and then we'll have you comment on it.
I think we all believe that by 2021 we will have a vaccine. We're working ahead of time with the manufacturers, with the pharmaceutical companies to try and actually have manufacturing capability ready to go. So as soon as those trials are finished, the vaccine can go immediately into the manufacturing. And the whole reason we got involved in this vaccine was to make sure there's equitable distribution.
Tremendous progress is being made on vaccines. In fact, we have ready to go in terms of transportation and logistics. We have over 2 million ready to go if it checks out for safety.
So there we have both the federal government, represented by President Trump, and Melinda Gates, private philanthropy, involved in setting up the manufacturing and distribution. Is it going to take globally a combination of private and public resources in order to do this equitably?
I think that that's very likely to be the case. I don't think that, I think, we need to get one thing to remember is that the data from New York City suggests very clearly that minorities and frontline workers were disproportionately affected. We need to be able, in order to, the word you use is a very important word, we need to have equitable distribution and vaccination. We need to ensure that people who have generally not been included in healthcare are in fact included in vaccination, and I do not doubt that a public-private enterprise will be useful.
We have 15 minutes left in our conversation. While we're talking about vaccinations, global public health experts have raised the alarm that the focus on COVID-19 has depressed the immunization of diseases such as polio around the globe. What will be the overall effect on public health of that outcome?
Well, that it will be doubtless unfortunate. I again have been urging and continue to urge people to seek medical care for diseases and continue their vaccination. It took a long time to vaccinate and to ensure immunity against these deadly diseases, and to give up now would be a terrible thing. So as long as these vaccines can be given in places that are safe, and we really need to think about ensuring that those places are safe, that both the vaccine giver and the vaccine recipient does not get accidentally infected by COVID, and reassuring people that we're taking the best possible precautionary measures is important. But it would be a terrible thing to have a vaccine against COVID and realize that, in fact, we're losing ground against diseases such as mumps, measles, rubella, polio, and other diseases that we have vaccines for.
Here in the United States, where those diseases have been mostly eradicated or contained, we have seen impressive statistics on the depressive amount of care for emergency rooms or for routine medical care that Americans have been taking over the past 5 months. What specifically has been the effect on your field, your specialty of cancer, over this time?
Well, let me just say one thing before you say that. I mean, let's not be cavalier about in the United States that these diseases are on the backswing. We know of communities where vaccination was not appropriately used, and there were outbreaks of measles. I mean, in the United States. So I would just advise people not to be cavalier in the United States and think that we live in a safe environment and therefore the vaccinations are a little more optional or a little more dispensable. So let's remove that misconception, but then let's talk a little bit about cancer. We have tried our best to make sure that the cancer care that we have been giving patients has gone on or will go on without with the least amount of disruption and interruption. Now, that's virtually impossible. But what has happened is that there's been a strong degree of prioritization. For a while, it was, we were not opening new clinical trials, which was obviously there was a delay in opening clinical trials. We're up again. So we are now reopening clinical trials. But for the routine care of cancer patients, we tried, everything that we could, including testing them before and after. We opened a testing facility such that they would not be infected. As you know, many of these patients on chemotherapy are immunocompromised, and I'm proud to say that most of the that we avoided, at least at Columbia, we've avoided most of the complications of COVID in immunocompromised chemotherapy patients with cancer, and we have mostly avoided interruption of vital cancer care. Obviously, any elective surgeries have been pushed back within the reasons or realms of safety. But aside from that, we're now slowly entering a phase in which trials are open, patients are back, infusions are occurring on time, testing is widespread. and the number of deaths that people have experienced from COVID have not been, have not been disheartening.
Will there be an impact on cancer research funding?
Well, I would hope not. I would hope that if there's one thing that comes out of this, terrifying tragedy, it is the fact that we recognize once again that science is of crucial importance. The world is still full of deadly, dangerous diseases that have the capacity to paralyze economies, and that the investments, $1 billion investment in whatever it might be, screening technologies, surveillance technologies, the production of medicines, may well lead to trillions of dollars of savings of money, but also more importantly, obviously, of human lives, which are invaluable. No value can be put on the 128,000 odd deaths that have occurred in the United States. It is immeasurably invaluable, and so I would hope that this would persuade Congress, rather than withdrawing from international and national bodies, rather than throwing suspicion at them, and rather than destroying their integrity and their funding, it would in fact increase funding, and that would be felt all across the board. By the way, I should tell you, just to give you one example, the COVID-19 vaccine platform for T-cell immunity that I'm working on with a company called Myeloid, again with full disclosure, it was initially initially devised for cancer. We readapted that because we realized we could, very rapidly induce a response, T-cell response, and a very brisk T-cell response, and understood that T-cell response may be very crucial for vaccination. So that's one example in which there's a deep level of cross-fertilization between these fields. Drug screening against COVID depends on very much the same facilities that do drug screening against cancer cells. So once they're not silos. These are very interrelated, and I would imagine and I would hope, just like I said, just like genetics has really transformed our understanding of COVID, the continuation of science funding will do the same.
How do you expect telemedicine to be transformed as a result of this?
One of the major pushes of the Governor's Committee, Governor Cuomo's committee, is to understand and to explore the use of telemedicine in the future. There's a subcommittee, I serve on that subcommittee as well. Telemedicine is very, very much part of this, and we're hoping that one of the things that COVID will remind us of is that without, it's really telemedicine is one of the major ways that we will proceed in the future. It will never be, just to be very clear, telemedicine is not the same as FaceTiming with your doctor. It requires platforms, it requires platform building, it requires confidence building, it requires a lot of regulation because you have to be able to bill, you have to be able to understand how the visit works. And so my own feeling is that a hybrid model will move forward in which you combine telemedicine with a face-to-face visit, and maybe that ratio, what that optimal ratio is unclear. Maybe it's 2 telemedicine visits to 1 visit in person, but that is we're still figuring that out. But just to remind people, telemedicine is not FaceTime with your doctor. Telemedicine requires platform, it requires integration with the existing medical system, integration with the existing medical records. It requires a whole series of things to occur, including a series of regulations by the state and federal governments that allow doctors to have a televisit and to be able to bill for that televisit in a manner that is compatible with the rest of their practice. So So that's what's happening in telemedicine.
Throughout our conversation, you have emphasized the importance of hard science and data and research on attacking COVID. But I wrote a quote down that you said, which is that in the short term, it's not the hard sciences, but the social sciences that are our best option. What are you saying there?
This goes right back. It's first of all, I should say that I do not want to make a distinction between hard sciences and social sciences. Social sciences are just as hard as any other sciences. In fact, they're harder. I should say the hard sciences and the harder sciences. By social sciences, I meant really behavioral change. One of the things that COVID has pointed out to us is that we need widespread behavioral change. We need widespread trust in science. And behavioral change, as you know, is one of the hardest things to enforce or to enact. We knew, just to give you one example from my own field, we knew that cigarettes caused lung cancer in the 1950s and 1960s. But it wasn't until the 1980s and 1990s, through a series of behavioral changes, federal and state interventions, as well as social and cultural alterations, that we really began to see in this country a diminution of smoking, especially by young people. So first of all, I don't believe that there's a kind of a silo between the hard sciences and the social sciences. But what I really meant by that statement was to say that in order to address what is going on with COVID, we very much need to understand how people behave and what the limits of those, how to change that behavior. The same with telemedicine. Telemedicine is, on one hand, a software platform, but on the other hand, it is also a behavioral platform. People have to be able to use it. What prevents them from using it? Why are patients reluctant, or they're not reluctant? Is it making their lives easier or harder? I mean, these are behavioral questions, social scientific questions. The distribution of the vaccine, whether how to get a vaccine out to billions of people, and how to vaccinate them, is a combination of biological sciences, the making of the vaccine, as well as the distribution and campaign around the vaccine. So far be it that these are not, that this is not a hard science, soft science distinction. It is a distinction between sort of, I would say, laboratory science and field science, both of which are very hard.
Well, we are out of time. As we close here, I want to invite people to find your New Yorker article that you've referenced about COVID-19, and if they'd like to see other of your work, your book, The Gene, and also your earlier book, The Emperor of All Maladies. Thank you so much for spending an hour with C-SPAN.
Thank you very much.
Thanks for listening to C-SPAN's Q&A. Subscribe wherever you get your podcasts, and you'll never miss an episode. And while you're there, please take a minute to rate and review us. You can also send us an email at podcasts@c-span.org with your questions, comments, or ideas. Your feedback is welcome.